Good evening, and welcome to AUA's Prostate Cancer Update 2024 Expert Guidance for Urologists live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this other activity for a maximum of 1.5 AMA PRA Category 1 credits. All persons in a position to control the content of a CME activity are required to disclose to the AUA as the ACCME accredited provider all financial relationships with any ineligible company, formerly commercial interests, during the previous 24 months. An ineligible company is defined as one whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. The AUA must determine if the individual's relationships are relevant to the educational content and mitigate any conflicts of interest prior to the commencement of the educational activity. The intent of this disclosure is not to prevent individuals with relevant financial relationships from participating, but rather to provide learners with information so that they can make their own judgments. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. You are prohibited from using or uploading content you access through this activity into external applications, bots, software, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. The AUA would like to thank Astellas, Lantheus Medical Imaging, Novartis Pharmaceuticals Corporation, and Pfizer Inc. for providing independent educational grants in support of this webinar. Finally, I'd like to introduce and extend a special thank you to our course director, Dr. Manaj Siddiqui, for his time, talent, and expertise in developing this program. Dr. Mohammed Manaj Siddiqui is a urologist and professor of surgery at the University of Maryland School of Medicine. He completed his fellowship in urologic oncology at the NIH National Cancer Institute and residency in the Harvard, Massachusetts General Hospital Urology Program. He completed his MD in the Harvard MIT Health Sciences and Technology Program at Harvard Medical School. He currently holds administrative roles of Chief of Urology for the Maryland VA Healthcare System, as well as Director of Urologic Oncology and Robotic Surgery at the University of Maryland, which he joined in 2014. I will now turn the course over to Dr. Siddiqui.
Wonderful. Thank you so much. And it's my pleasure to be here and join you all tonight. Thank you, everyone, for joining us. So the activity goal for today, based on a documented need from the AUA Advanced Prostate Cancer Global Needs Assessment, the AUA is providing additional education to update APPs on the latest advance in the management of hormone-sensitive prostate cancer, including treatment intensification. It's also to update urologists, which I think is today's goal, actually. The learning objectives. At the conclusion of this activity, the learner will align their practice with current AUA guidelines and recent amendments pertaining to screening, diagnosis, management of prostate cancer. Our goal is to also determine appropriate use of biomarker testing as it relates to the diagnosis and therapy. Want to talk about analyzing the role of imaging and types of imaging that aid in staging patients with prostate cancer. 4, implementing appropriate treatment paradigms for metastatic prostate cancer, including treatment intensification. And lastly, want to discuss the role of genetic and molecular profiling in the personalization of prostate cancer treatment plans. So we have a spectacular panel here today that really will help us cover this broad range of topics. It's my pleasure to now introduce our 3 subject matter experts here. I'll begin with Dr. Maria Baker. Dr. Baker is a genetic counselor and a professor of medicine at Penn State. She received her master's degrees in genetic counseling from the University of Pittsburgh Graduate School of Public Health in 1985, and her PhD doctorate degree in genetics from Penn State University College of Medicine. in 1991. She is a diplomat of both the American Board of Medical Genetics and the American Board of Genetic Counseling, with dual certification as master's trained genetic counselor and a PhD medical geneticist. Dr. Kelly Stratton is a urologist and associate professor of urologic oncology at the University of Oklahoma Stevenson Cancer Center. Prior to joining OU's Department of Urology in 2014, he completed his fellowship in urologic oncology at the Department of Surgery in Memorial Sloan Kettering in New York City, and his residency at Vanderbilt University Medical Center, Department of Urology. Completed his MD with special distinction at the University of Oklahoma College of Medicine in 2007. We're particularly grateful to Dr. Stratton, who is pinch hitting today after one of our previous panelists was sick this morning. And so thank you for joining us today, such short notice. Dr. Tian Zhang. Dr. Zhang is a medical oncologist and an associate professor in the Department of Internal Medicine at UT Southwestern Medical Center and a member of the Division of Hematology and Oncology there. She's an associate director of clinical research at the Simmons Comprehensive Cancer Center. Dr. Zhang earned her medical degree from the Harvard-MIT Health Science and Technology program at Harvard Medical School. So I have special love for the HST program also, and she joined the UT Southwestern faculty in 2021. Thank you, all three of you, for joining us. Wonderful. So we're gonna kick this off. We're gonna go ahead and just jump right into our topics. Let's get started by discussing how we're going to structure the next hour, as we have a lot to cover today. And it's easy to get lost without some structure. So our goal is to discuss what is the most current and best practice with regards to biomarkers, imaging, treatment paradigms, and genetic and molecular testing across the spectrum of prostate cancer, at least in the hormone-sensitive portion of it. Want to highlight some of the most strong evidence AUA guidelines along the way. So this is a tall order, but there's some structure we can use to help us cover this substantial ground. We will run through these topics by phases of a patient kind of stage and journey, if you will. So we'll start off with the screening and diagnosis segment, then localized prostate cancer, and then advanced hormone-sensitive prostate cancer. We'll, please, for the audience, go ahead, and if you have questions, clarifications and whatnot that you'd like us to kind of delve into as a group, go ahead and send those in, and we will be answering those by segment. So we won't be saving them till the end of the day. We'll instead, we'll answer all the screening and diagnosis ones, then move on to the next section, and vice versa. To keep things somewhat manageable, we will exclude from tonight's discussion castrate-resistant prostate cancer, and we'll only touch on topics related to radiation therapy in somewhat limited ways. Now, regarding the AUA guidelines that we will cover, it's worth reminding everyone that there are 5 sets of prostate cancer guidelines published on auanet.org. Okay, these 5 sets are the early detection guidelines published in 2023, the localized guidelines published in 2022, salvage therapy guidelines published this year, 2024, advanced prostate guidelines published in 2020 with amendments last year, 2023, and then also a hypofractionated radiation therapy guideline, which was published in 2018. In all, these guidelines contain 167 statements associated with best practices in the care of the spectrum of prostate cancer. Each statement is given a evidence strength, okay? Level A, B, C, expert opinion, and clinical principle. And so level A is the highest certainty. And there are certain criteria that lead to a level A level of strength, okay? And so today, we're not going to cover all 167. We will cover the 16 statements that are level A statements of evidence, and we'll explicitly highlight those for all of you as a reminder of just kind of what is published in terms of high evidence quality care guidelines. So to start off, I'm going to actually start off by asking Dr. Stratton a question. So, Dr. Stratton, what are your current day practices with regards to prostate cancer screening and diagnosis? And what are your thoughts in particular with the use of MRI, fusion biopsy, and biopsy approach with the transrectal and transperineal approaches?
Well, thank you for that question. There's a lot to dig in here, and I think it's extremely important. And we see this as the effects of what happened in COVID when prostate cancer screening really stopped for a short period of time. This is a very important thing to mention to men. It's part of shared decision making. So it's important for urologists to feel comfortable discussing the potential benefits of prostate cancer screening with their patients. And even more importantly than that, it's important for urologists and the urologic community to talk with primary care physicians about the potential benefits of prostate cancer screening, because in many instances, they're in the trenches doing this screening. But the cornerstone of prostate cancer screening remains the PSA test. And that's where the AUA guidelines focus us to use PSA as a screening test and to offer PSA screening to men who are between the ages of 50 and 69. And there are a select group of men who may benefit from screening early, such as those with African American ancestry, those who have a family history of prostate cancer, or those who are known to harbor a genetic mutation that may put them at risk for prostate cancer. So earlier screening is something to consider in those men. And in fact, getting a PSA baseline test is something that the AUA guidelines suggest may be beneficial to those earlier as well, between the ages of 40 and 50 as well. So PSA testing is very important. And the frequency of testing can be altered based off the patient's preferences and the risk for prostate cancer. So, for instance, in that 50 to 69-year-old, if they have a reassuring PSA, the frequency could be every 2 to 4 years, and it can be more frequent if necessary. In my practice, many patients, we not only screen them for prostate cancer with PSA, but we're also managing other men's health items. And so we see them annually, and in many instances, the patients are happy to get their PSA once a year. And so certainly that would be acceptable from the AUA guidelines, but it can be also spread out based off of their risks. Another thing that you mentioned would be imaging. And certainly this has become very important as we try to improve screening. We've always known that PSA screening may identify men who have indolent or insignificant cancer. And so MRI can help us identify men who may be more likely to have clinically significant prostate cancer. And in fact, the AUA guidelines suggest that clinicians can use an MRI prior to an initial biopsy to increase the detection of clinically significant prostate cancer. Specifically, the guidelines mention that radiologists should use PI-RADS as a scoring system to identify these clinically significant lesions, and that patients should have a biopsy focused on that in men who are biopsy naive. And these biopsies, which we refer to as fusion or targeted biopsies, should be directed at the suspicious lesion. But men can also, or urologists can also provide a systematic biopsy in that instance. For those men who don't have a suspicious lesion on MRI, but may still be at risk for clinically significant prostate cancer, the AUA guidelines suggest continuing with a systematic biopsy to ensure that those patients are evaluated. There's also an option to use urine or serum tumor markers to further risk stratify and determine men who may want to undergo biopsy. So in my practice, I primarily rely upon MRI as an image-guided method to identify men who would benefit from a prostate biopsy and to guide that biopsy. Importantly, our methodology of biopsy has been changing recently, and the tide is shifting from a transrectal ultrasound guided biopsy to a transperineal biopsy. And that's based off of the concern that biopsies may lead to a risk of infection and other side effects. And so we have studies like the PROBE-PC study and the PREVENT study that have looked at men undergoing biopsy and comparing transrectal biopsy to transperineal biopsy. In those instances, they showed a very similar cancer detection rate. So I think that opens the window to transperineal biopsy. Fortunately, they also showed a very low risk of infection even in transrectal biopsies. So I think urologists who are interested in transitioning to transperineal biopsy should know that their cancer detection rate should be similar to the transrectal biopsy, but that there may be a lower risk of infection. And for those urologists who are still using transrectal ultrasound biopsies, know that in many instances their risk of infection still remains sufficiently low that they can continue that approach as well.
Wonderful. That's great. While we're talking about some of the studies, I think it's worth mentioning. So there's actually right before this whole thing started, 2 hours ago. So this is truly fresh off the presses. In New England Journal, they just published the Gutenberg 2 trial, which is a screening trial that's been going on for a really long time now, 15 years, I think. And that trial has actually transitioned to a randomization for screening practices of MRI versus MRI target biopsy only versus MRI plus 12 core to look at the outcomes of detection of clinically significant and clinically insignificant prostate cancer. And so they found a 57% reduction, a massive reduction in detection of clinically insignificant prostate cancer if you remove the 12 core, without a clinically significant decrease in detection of without a significant decrease in detection of clinically significant disease. So I mean, this is still going to be a hot topic of discussion, and I think we'll all have to kind of spend a little time analyzing and understanding these results. But it's an area that I think we're still all trying to understand and evolve with.
Yeah, and certainly there is concern for the cost of using MRI before biopsy. That's something that is asked in the chat box. MRI before every biopsy could help in identifying men with clinically significant prostate cancer. Certainly, if we're using MRI to prevent biopsies in the future, that may lead to cost benefits in addition to avoiding the detection of insignificant cancer. So I feel like it's hard to say that we're going to initially reduce cost, but in the long term, we may reduce the cost by avoiding unnecessary biopsies, avoiding the detection of clinically insignificant prostate cancer, and maybe even avoiding systematic biopsies as well. And so, I think MRI may be helpful, and the cost of MRI may be coming down in the future as well.
Yeah.
As far as using DRE as a initial screening exam for prostate cancer, the AUA guidelines provide an option for the use of DRE. The DRE as a screening alone for prostate cancer is not recommended. PSA is the foundation for prostate cancer screening. There are many reasons that a primary care physician may want to do a DRE in addition to prostate cancer screening. And there are many reasons that a urologist may want to do a DRE. So I think DRE can complement PSA screening. It's rare in my practice that I would do a prostate biopsy based solely on a DRE finding. So I think it's complementary. It's something to consider. It's something to discuss with patients. But the AUA guidelines gives flexibility in that arena. And then in regards to additional testing like 4K or the MPS 2.0 score, these are tests that I feel like can be very helpful for urologists who are working with the patient to determine the potential benefit of prostate cancer biopsy, of a prostate biopsy. And in that instance, most patients appreciate the additional information. They are interested in seeking multiple perspectives on the potential benefit, and so you can use those tests. You can also use PSA density, and you can incorporate the MRI and pyrite score. There are many different avenues to trying to work with a patient who may be at risk for prostate cancer and may be concerned about undergoing a biopsy.
Wonderful. Thank you. I mean, this has been great. So I'm gonna transition a little bit into, but staying on this topic of risk stratification. So, I'm gonna bring in Dr. Baker now. So, Dr. Baker, we occasionally get patients with family history of prostate cancer who want to understand their risk, not necessarily from these testing modalities, but actually from a more underlying genetic risk perspective. And so, thank you again for joining us, because I think you have a lot that you can add with this perspective. Could you perhaps lay some of the foundation for the group of what is an optimal way a urologist should navigate these types of requests and just this working up a patient in this type of space? What information should they gather? What options should they offer patients? What are resources available to patients and clinicians alike to navigate the question of genetic predisposition, genetic predisposition to prostate cancer, particularly if the patient does carry some risk factors?
Certainly, and thank you for the invitation. I appreciate it. So in the clinic setting, the family history is key. Taking a thorough 3-generation family tree, of course, you likely would not be drawing that family tree out like the genetic providers do, but at least eliciting the family history out to the 3rd-degree relatives. So that's asking questions about, siblings, aunts, uncles, cousins, grandparents, even going back to great uncles and aunts, which many people admittedly don't know those relatives. But the approach that you can take is one in the clinic setting, which personally I don't feel is ideal. You have very limited time in the clinic setting. And so the alternative approach of you have a new patient, mailing them a new patient information packet that includes a family history survey, or as we do within the Penn State Cancer Genetics program, we actually send an electronic survey that patients complete prior to the appointment. And before they even come to the appointment, we've already got a family tree drawn so that we can delve into evaluating that history and educating the patient whether it raises concern for a genetic predisposition where genetic testing may be appropriate. In addition, for example, on our Penn State Cancer Institute website, we have an electronic survey that is available for anyone in our community and beyond if they want to know whether or not they're at increased risk, where they would be a candidate for genetic counseling and testing. And our program brochures have a QR code that they can scan to take the survey. So we've tried to implement a number of ways where maybe less traditional ways where it's not taking up the time of the provider during the clinic because they have very limited time available. Once you have that information, then the challenge becomes is recognizing whether or not there are warning signs or red flags where maybe that patient should be referred on for genetic counseling and testing. And that's where we mainly refer to the National Comprehensive Cancer Network Guidelines, or NCCN. And these guidelines are updated multiple times each year. In fact, just 2 weeks ago, they updated the testing guidelines for prostate cancer. In some respects, it can be somewhat easy to implement those guidelines. For example, any male with metastatic, high-risk, very high-risk prostate cancer is an automatic candidate for genetic counseling and testing. If they have low-risk prostate cancer, though, then you need to add in some family history information or whether or not they have Ashkenazi Jewish ancestry to determine if they're a candidate. And that's where it can get a little bit complicated. It's almost, might be better to take that one page from the NCCN guidelines, laminate it, and have it in every clinic room so that the provider can quickly determine do they meet guidelines or not for a referral. And so, if the patient is a candidate for genetic counseling and testing, then you need to decide, what constraints do you have within your clinic setting? Do you want to refer that patient via the traditional approach to a genetic counselor or a genetic counseling assistant who may be in your institution. They may be available in your local community, if not in your own private practice setting, or we even have telehealth genetic counseling available now. So if you don't have those resources immediately available to you, all you would need to do is Google "find a genetic counselor." The URL is www.findageneticcounselor.org. And you can specify that you want a cancer genetic counselor as opposed to a prenatal or a neurogenetic counselor, and then indicate what state you live in, what your zip code is, and it will populate with genetics providers in your area, either for in-person counseling or by telehealth. So that's the traditional approach. Alternatively, you could implement having a genetic counseling assistant within your own clinic setting, or training one of your staff members, maybe a nurse practitioner, a PA, to coordinate the genetic testing in collaboration with some genetics providers that they can reach out to if they have questions. Some centers have actually even developed a genetic testing station, which is not specific to one clinic, but it's there within the institution. And, gyn-onc can refer a patient, urology can refer a patient, gastroenterology, and they just go to the genetic testing station, and typically they'll have a genetic counseling assistant or a genetic counselor in that station to implement testing that very day while the patient is there. So I think with that, I'll turn it back and see if there are any questions that come in that we need to discuss further.
Perfect. Great. Thank you. And I love the website findageneticcounselor.com. I think whoever came up with that was very smart.
.org. .org.
It's a great idea. I'm gonna keep things moving for timeliness, and I think that one of the things you maybe notice, we'll try to also interact with you all, kind of both in the live panel, but also in the chat windows to the extent that we can. And as I think there's just so much to discuss today. And thank you, Dr. Baker, and we'll be back to you in a few minutes for more. So now coming back to Dr. Stratton, and transitioning actually to kind of the topic of localized prostate cancer. So we're beyond screening. Now we're on diagnosed prostate cancer. Can you run through how you risk stratify and line up treatment options for patients starting, for treatment for patients diagnosed with prostate cancer, kind of starting with the low risk side and working your way up along that spectrum for localized disease?
Sure. I think men are increasingly becoming comfortable with Gleason grade group. And so I'd really like to start there. You have their PSA usually from before the biopsy, a clinical stage that you may get from a DRE, and then grade group and even tumor volume within the biopsy can all be used to help risk stratify patients. For those who are low risk, the guidelines recommend active surveillance as the preferred management option. And I think, we have been greatly aided by the debate about whether to even call grade group 1 cancer or not cancer. And so, introducing that debate into the discussion, I think really helps frame the risk of low risk Gleason grade group 1 prostate cancer. For those who have favorable intermediate risk prostate cancer, we can discuss active surveillance or radiation or even surgery. Some men will also ask about ablative treatments like cryotherapy or HIFU. And, I think that those are all things that are a spectrum of treatment. And then for higher risk disease, we really kind of focus in on radiation therapy and surgery are primary treatment options. So for men who have low risk prostate cancer, we're thinking about active surveillance. So in that instance, imaging with an MRI and their PSA trajectory, understanding that, I think helps them anticipate the future as far as when their next imaging would be, if they are going to undergo a confirmatory biopsy and so forth. There are gene expression assays like Decipher or Prolaris that may be helpful. Typically, I use those in the intermediate risk patients, and in many instances, patients undergoing radiation therapy, the radiation oncologist may be interested in knowing their, for instance, Decipher score to help determine whether they would be receiving androgen deprivation therapy or not. So the guidelines suggest that men who are on active surveillance should undergo an MRI to aid in risk stratification. And I think that that's very helpful for them, and also for men who may be undergoing radiation or surgery for intermediate risk prostate cancer. So that's kind of how I frame it. And then work with patients to identify a treatment that may align best with their preferences and concerns about quality of life and the impact of treatment.
That's great. I think, and of these topics that you discussed, actually, one that was, also mentioned in kind of the question. So what do you do when the MRI prior to, like, someone's going to get surgery and the MRI shows this kind of like abutment or bulging, of the tumor against the prostate edge, and
That's a great
concerning for
question.
possible ECE.
Yeah, I mean, I think early in the MRI era, there was a great deal of concern, to a degree that surgeons would even avoid nerve sparing based off of abutment or engagement of the capsule. The sensitivity is only about 50%, so it's kind of a coin toss on exactly how extensive the disease will be. And so I think as we have grown to understand the benefits of MRI and its limitations, we've developed some confidence in applying our surgical skills to still do a nerve spare if everything looks acceptable in the operation. It's something that we can talk with patients about and make sure that they're aware, and then proceed with surgery in a way that we hope to have a negative margin, because I think that that's very helpful down the road. So MRI is very good at identifying a lesion. It has limitations in as far as identifying extracapsular extension.
Yeah, I couldn't agree more. I think this really speaks to, as this imaging is becoming more ubiquitous in our field, and especially in prostate cancer, for urologists to really look at the images, because when you see the images, and learn to identify the lesions, with the guidance of the radiologist saying there's a lesion there, it helps, right? But then find that lesion and see how it really should impact your management plan, your surgical planning, and whatnot.
Certainly, it's all a collective picture, in the same way that many of these tests are not necessarily predictive of the future. They're more prognostic, and so we have to be mindful of that.
Yeah. You knocked out two of the questions already. I'm going to go to Dr. Baker now. So Dr. Baker, you have thoughts on genetic testing and active surveillance, as well as in patients with more high-risk disease, all in this localized prostate cancer space?
Yeah, here again, family history is key when you're working with a patient who has, a low-grade prostate cancer. So, referring to those NCCN guidelines, we do know that there are a handful of two of genes that are known to predispose to prostate cancer. Some of them are more likely, notably BRCA2, for example, to predispose to a more aggressive type of prostate cancer. And it's important to know this information because NCCN is now incorporating a change in management recommendations, recommending prostate cancer screening starting at 40 and annually thereafter for males who have either a BRCA2 mutation or if there's a TP53 mutation for Lee-Fermini syndrome. Otherwise, they're a little bit more soft in the recommendations for the other prostate cancer susceptibility genes. They are recommending that they consider. So there's a subtle difference there where they recommend for some and they recommend consideration for others. Yeah, family history is key here, especially with the low risk prostate cancer, because they're not going to qualify in their own right unless they have Ashkenazi Jewish ancestry or unless there's some family history that's going to raise it to a level. Of course, I will contradict myself there. I think coming down the pike is universal genetic testing for every patient with a solid tumor diagnosis, because we have a study out of Mayo called the Intercept study, where they looked at patients with 8 different types of solid tumors, including prostate cancer, and roughly 13% of those patients had an underlying germline predisposition. So we're seeing this with ovarian cancer, pancreatic cancer, where we are starting to test all patients. Breast cancer, based on American Society of Breast Surgeon guidelines since 2019, we've been offering testing to every patient with breast cancer, genetic testing. So I think it's just a matter of time, and with the cost of testing continuing to decrease in price, the challenge is going to be, how do you enable all those patients who would then qualify to access genetic testing? What providers are you going to use? What alternative service delivery models? I work in a green building, so I need to move around a little bit more. So.
Wonderful. And while we're on this, I mean, it's fascinating, this idea that testing, essentially everyone with cancer could become a standard practice. One of the questions that's asked in the chat, and I'm sure many have kind of run across, is what considerations for some of these other aspects of life, insurance coverage and privacy and all these types of things, should urologists be aware of as they're recommending patients to get testing?
Yeah, very good question, because that historically had been a barrier for patients pursuing genetic testing. When I started the cancer genetics program in 1998, just a couple years after the BRCA1 gene and 2 genes were discovered, and just a little bit after the Lynch genes were discovered, there were many patients that were very ambivalent about pursuing genetic testing for 2 reasons. One was the cost of the testing at the time, and we were not as successful in getting testing covered back then. And 2 was the concern about genetic discrimination, whether genetic information could work against them or their family members in some way. And fortunately, in the years that have passed, there have been a number of federal laws enacted that protect us against genetic discrimination. And this is part of our genetic counseling session, a traditional counseling appointment prior to the patient undergoing genetic testing, where we mention the fact that we have HIPAA, we have the Affordable Care Act, we have the Americans with Disabilities Act, which protect health insurance and employment. But unfortunately, it is important to point out, we don't have any federal laws that protect life insurance, long-term care, and disability insurance. So we do discuss that with the patient. We mention that they can get all the no questions asked life insurance as part of their benefits package at work, since that's based on employment, not health history. It's only if they would want higher levels of coverage where they may need to fill out an application. And sometimes when patients learn about that, they might put a pause on the genetic testing, and they'll speak with their children, they'll speak with their husband, or vice versa, their partner, and think that through. Do they want to purchase private life insurance before undergoing genetic testing? So it's a valid concern. And we're not typically in an urgent situation unless surgery is pending, that we have to do the genetic testing right there. We want patients to feel comfortable and at their pace if they're going to move forward.
Wonderful. I'm going to now move up to move into more of the aggressive cancers, and bring in Dr. Zhang. So we're now entering territory that overlaps with your practice, particularly in the high-risk patient population. What type of further workup do you like to see in patients who plan to go, say, like have high-risk prostate cancer, radiation and ADT as their plan? And especially with regards to the systemic therapy, the ADT portion, what kind of durations? Do you have thoughts on like what type of durations and the use of some of the more traditional leuprolide type agents versus newer agents, such as the agonists and the oral agents as well?
Sure. I'm happy to talk about, some of the workup that we see. We don't advocate for conventional imaging for unfavorable intermediate risk Gleason 7 localized disease, but we do want to see these CT bone scan types of workups for high risk Gleason 8 to 10 prostate cancer. And since the approval of the PSMA PETs, we've seen a really big uptick of PSMA PET imaging for staging and high-risk localized disease. And those PET scans are often picking up on PSMA avid lesions that pose a new, earlier metastatic category than we had previously dealt with. So I'm sure many of my medical oncology colleagues are partnering with urology colleagues out there in order to help those patients kind of navigate this PSMA positive earlier metastatic disease. In terms of hormone deprivation and ADT duration, my practice is quite in line with the AUA guidelines. So with Gleason 7 unfavorable intermediate risk prostate cancer, I give about 6 months of ADT, and then in high risk localized prostate cancer, I would opt for at least 18 months, and generally try to shoot for 2 years as long as the patients are tolerating well. And this is concurrent and in conjunction with people's radiation therapy. And a few trials have studied this more formally. There was a DART 0105 trial a few years back. 50% of those patients had high-risk prostate cancer. And in that cohort, they were looking at 18 months of ADT with external beam radiation therapy compared to 4 months ADT, showing improvement of metastasis-free survival and also overall survival. And then there was another trial called RADAR, where about 2/3 of those patients had high-risk prostate cancer. And again, 18 months of ADT compared to 6 months of ADT improved distant progression-free survival. And in terms of the biomarkers, we've seen some interesting biomarkers recently where Artera AI and also Decipher scores can be helpful for us in terms of considering who should be getting a short course of ADT compared to no ADT for intermediate risk disease. In terms of all the treatment options that are now available for ADT, there's a number of different GnRH agonists, and then also 2 GnRH antagonists available. The newer antagonist, Degarelix, is subcutaneous monthly formulation, and then the oral Relugolix, which I think has had a lot of uptake recently, is given orally and has a very short half-life. And the registrational trial for Relugolix, HERO, was a phase 3 comparing relugolix to Lupron for a year, showed really similar testosterone suppression with about a third of the cardiovascular events and also faster testosterone recovery. So I would choose those patients who will have shorter courses of ADT and also those with significant cardiovascular comorbidities to think about relugolix for them.
That's great. I mean, it's been a rapidly evolving space, and a lot to keep up with. While we're on this kind of topic of just how this space is changing, how about any thoughts on the combination therapies that are out there, and do they have a role with the localized prostate cancer population?
Sure. So there were about 2 Stampede cohorts. I really commend the British for doing the Stampede trials. But 2 of those cohorts had patients with high risk localized disease and treated them with abiraterone, prednisone, and then one of the cohorts also added enzalutamide. So the short answer is that if patients have 2 of the risk factors, which are T3, T4 disease, Gleason 8 to 10, or PSA over 40, if you add abiraterone and prednisone to ADT, they will have improved metastasis-free survival as well as overall survival. And so it is part of my practice to consider those patients with high-risk prostate cancer and think about adding abiraterone for those patients. In terms of the PSMA PET positive, I have this fascination now that this population is really burgeoning in our clinics. The PSMA PET positive population, and should we intensify treatment for them? It's really a data-free zone at this moment, and multiple studies are underway. But we sort of took a retrospective look at our UT Southwestern cohorts with PSMA PET positive disease, but CT negative disease, found that those patients have pretty great outcomes, very low rates of progression to castration resistance, and also very low rates to developing metastatic disease. So I'm sure much more to come in terms of intensifying versus not for that patient population, but certainly something that is on the radar to be on the lookout for.
Yeah, that's great. We're going to be talking a lot more, I think, about PSMA as we kind of continue down this progression of disease. But I think I would agree with you that the utility of PSMA continues to become more and more evident, and I think that there's a lot of areas where it's very helpful. That's great. I'm going to transition us now to the next segment, which is post-treatment failure patients now. And then, we've had a lively chat on the side, and please do keep those questions coming in. I'll try to discuss them in the group portion when we can, although trying to keep us on time too. And so we'll do a lot of those over text as well. So now, transitioning to this post-treatment failure, we're going to focus on patients who've had, say, like radiation and now have a recurrence. So maybe we'll go back to Dr. Stratton for this one. How do you monitor and work up a possible biochemical recurrence after initial treatment?
Sure. So, after surgery and radiation, we rely heavily upon PSA to help guide us in identifying patients who have recurrence. For those patients who are undergoing radical prostatectomy, we don't typically use adjuvant radiation therapy. So we're really looking for men who have a rise in their PSA and or persistence in their PSA after prostatectomy. For those with radiation, we're looking for a nadir, but we're being cautious not to react to a bounce. And so that's the real art of medicine there. In those who have, for instance, risk factors for recurrence, we may be more vigilant, like a man who has high risk prostate cancer, who underwent prostatectomy or had positive margins. For those who are at risk for recurrence and have a rising PSA, we would want to be sure that we don't miss metastatic disease. So in those instances, we could use a PSMA PET and evaluate for sites of recurrence based off of that. For those who have radiation therapy, if we're looking for a local recurrence, so these would be men who don't have any evidence of metastatic disease, I feel that it's important to biopsy them to confirm local recurrence, and that can help identify men who may be candidates for salvage therapy. So I think the combination of PSA, imaging, including PSMA PET, and then biopsy if there's a concern for local recurrence.
That's great. I mean, we've come so far, I'd say this, and this is just in the brief period that I feel like I've been practicing, that, last 5-7 years, the maturity of these imaging modalities, the availability of and kind of approval of some of these imaging modalities, the ability to do target biopsy has really changed how we manage patients in this space. And it allows for kind of more precise determination of recurrence, which I think, we used to do just adjuvant. Adjuvant was like standard, and now it's not, and that itself is a remarkable, I think, advancement.
Yeah, I think that it's in line much more with the preservation of quality of life. We're really looking for treatments that may impact patients' longevity, and understanding that we have a very high bar in men who have had prostate cancer treatment and may have a detectable PSA, but may not be at risk for metastatic disease. So as far as recurrence after radiation therapy, some men will be able to undergo additional local therapy, and that's very important as well, because in patients who have failed all local therapy, we now have new options. So in those who are candidates for local therapy, the biopsy can help guide that, and then they could consider things like cryotherapy, other ablative treatments like HIFU, re-radiation, or salvage prostatectomy. So there's a new window of opportunity for salvage in men who've had radiation therapy, and I think it's important to discuss that with patients.
Yeah, that's great too, that there are more options, and I think that these options can also be catered to the nature of the recurrence and the anatomy and the location of the recurrence. And in many situations, it's nice having extra tools to treat these patients.
Sure. And in those who have now failed all local therapy, 2 trials have provided us with evidence to support combined androgen deprivation therapy. So I'm not sure if we're going to talk about this later, but the EMBARK study and an additional study have shown that, for instance, the addition of enzalutamide or apalutamide may help these men and reduce their risk of metastasis or PSA progression-free survival.
Well, that's a perfect cue to bring in Dr. Jang here. So what are your thoughts, Dr. Jang, on the use of ADT in these patients?
Yeah, I often will consider the rate of at which point they're recurring, right, with biochemical recurrence. So time to recurrence is important, and then also their initial Gleason grading. And if they had Gleason 7 disease with relatively short time to recurrence, I would still give 6 to 12 months of ADT. If it's been many years since their prostatectomy, and now they're late recurring disease, sometimes we will skip the ADT and go straight to radiation. With higher risk, Gleason 8 to 10 initially, and usually these folks are recurring relatively earlier. We would still prefer to give 24 months of ADT, and the Radicals HD trial was one in this post-op population that compared 2 years versus 6 months, and then that high-risk patient population found 2 years to improve that time to disease progression. So certainly adding ADT for that high-risk population, especially those who recur earlier rather than later.
That's great, Dr. Jang. Thank you. Do you use any of these biomarkers in this setting?
Yeah, I think that's still an evolving picture. We have some trials now that are looking and using Decipher scores, but so far, nothing really has shown us these patients, the high risk decipher are absolutely the ones who have to have intensification or not. I do implement them as part of trials that are ongoing. I think much more to come as the NRG trials read out in the salvage setting.
That's great. Thank you. I think we do have a little time to take some of the questions, and I think one that has been commented in the text, but I'll have the group also discuss is so after a radiation recurrence, should biopsy of seminal vesicles be standard? And Dr. Stratton, what's your practice in that space?
A lot of these men who I'm seeing in clinic are interested in salvage cryotherapy. And in that instance, it's difficult to freeze the seminal vesicles, kind of impossible, just anatomically. And so if they have disease in the seminal vesicle, they would be at risk for recurrence. And so in that instance, I oftentimes will attempt to biopsy the seminal vesicle to assure ourselves that we don't have an early failure after salvage cryotherapy. Now, if men are planning to undergo salvage prostatectomy or radiation, then you may be able to get away without a biopsy of the seminal vesicle. But in every so often, you'll see a man who has a positive biopsy, and in that case, I don't offer them cryotherapy, so it's meaningful to me.
And I've more or less moved away from salvage prostatectomies. Are you still doing some, or who would you? I mean, I did one last year in a really young patient. And I'd love to get your thoughts too. Like, are you still doing them, and who would you offer it to?
Well, salvage prostatectomy has a very high risk of incontinence. And so I think it's in men who understand that and are willing to balance the risk of recurrence and the potential for cure with the risk of incontinence. And I do think in some younger men, they may be more resistant to incontinence, or they may be more willing to treat incontinence later and understand that a prostatectomy may afford them the option of cure and avoidance of androgen deprivation therapy. When I'm talking with men who've had radiation therapy, who are seeking salvage treatments, my frame of reference is often in light of androgen deprivation therapy. So if a gentleman is particularly interested in avoiding androgen deprivation therapy, then I want to generate a treatment strategy that may keep them from needing androgen deprivation therapy in the near future.
Wonderful. Okay, well, I'm going to transition us to the final segment of this evening, which is advanced prostate cancer. And so, Dr. Zhang, I'm going to come back to you here to lead us off on this topic. Can you take us through how you risk stratify a patient presenting with de novo metastatic hormone-sensitive prostate cancer?
Yeah, sure. And this space has really expanded in the last 10 years or so as we first had results of the CHARTED trial in 2015 showing the benefit of docetaxel in this space. And so really the high volume, low volume criteria come from the CHARTED trial. And thinking about more than 4 bone mets, the presence of non-axial skeletal mets, and then any visceral mets having high volume disease. In my practice, I also think a lot about discordance with lower PSAs with concurrent metastatic disease. I think of those as being a bit more anaplastic, less AR-dependent disease. And then just 2 weeks ago at the European Society of Medical Oncology meeting, there was a really interesting and compelling study of using the Decipher score to predict for docetaxel response based on the STAMPEDE trial. And it was really interesting to me because they could use a high-risk Decipher on the localized archival tissue to then predict for patients with metastatic disease who would benefit from docetaxel. And I think that it really gives some objective criteria to this sort of anaplastic state of the low PSA, but having metastatic burden, that the Decipher genes that are tested could potentially pick up on things like P10 or P53, CMYC perhaps, that all kind of come into this category of higher risk prostate cancer or anaplastic disease that responds more to chemotherapy.
Yeah, that's great. Yeah, and you mentioned kind of how everything's changed with especially some key trials such as the Charted trial. I mean, it's amazing how impactful a handful of trials has been in this space, and how we have a field have gone from Lupron, Leuprolide for everyone, maybe with some biclutamide, which, if the urologists and just anyone on this this webcast, podcast, whatever you want to call it, like, it takes one thing away, it is the wrong answer now to give a metastatic prostate cancer patient monotherapy, leuprolide. And so what is the correct what is the nuanced correct? I know there's not one correct answer, but what is the nuanced correct answer from your perspective, Dr. Zhang, on how to treat these patients?
Yeah, as you mentioned, there's been a number of trials, right, to support docetaxel use with Charted, abiraterone with Latitude, and enzalutamide. There were 2 trials, ENZAMET and ARCHES, and then apalutamide with Titan. And then again, also 2 weeks ago at the European Society for Medical Oncology meeting, there was a trial, phase 3 trial called ERA-NOTE, presented for metastatic hormone-sensitive disease that was ADT versus ADT with darolutamide. And so, my take home really is that none of these have been compared head to head to each other, right? We can't say any in particular for AR targeted therapies are any better than the others. But when I'm seeing a patient in clinic, I'm often talking about side effect profiles and also the access issue, right? So the financial picture of copays for a lot of these specialized medications are quite high. Abiraterone of all of them is the only one that's become generic and easier to access. And so I'm putting all of those in context as I'm seeing a new patient with metastatic hormone-sensitive disease. And to harken back to the earlier portion of this discussion, anybody also in that first diagnosis of metastatic disease, we're also talking about germline genetic testing too. So a lot to pack in that first visit. But there's certainly a number of doublets that are available, approved, and I hope everybody takes away from this session that we should be adding and intensifying treatments for metastatic hormone-sensitive prostate cancer.
Yeah, that's a great message. I'm going to pull in Dr. Stratton here. So, I mean, this space has gotten complicated, but these drugs are still very well tolerated, and urologists have been giving ADT kind of in parallel and collaboration with our medical oncology colleagues for a very long time now. And so, there's variable practice on how much urologists are either feel comfortable or are set up to give these more kind of involved treatments, but it is certainly something that is done in many urology practices. I know, Dr. Stratton, that you do some of this in your own practice. Do you have advice on to urologists if they're interested in kind of treating these types of patients with these various combination of drugs, on what kind of infrastructure and process they need in their clinics to manage these patients?
Absolutely. You know, a multidisciplinary approach has been found in many instances to be beneficial to patients. And urologists who are interested can have a varying degree of involvement as a part of that multidisciplinary team. It really does take a multitude of people to help advanced prostate cancer patients get the best possible care. A urologist, a medical oncologist, a radiation oncologist, a geneticist, nurse navigators, physical therapists, nutritionists. There are so many different avenues with which we can collectively help patients. Certainly from a urologist perspective, as we move these treatments earlier into the spectrum of care, they are being introduced to urologists, whether we want them to be or not. And so I think there is an opportunity for urologists to increasingly become involved. Just as I look through guidelines as far as use of, for instance, abiraterone, there are many instances now that abiraterone is an option for men without metastatic disease. So, for instance, those undergoing radiation with high-risk disease, or those with a PSA recurrence who are receiving radiation, there's some potential option for that as well. And so, you know, I think as a urologist, we see that the window is opening for advanced anti-androgen treatments and other treatments as well. At the same time, we are increasingly respectful of our colleagues who provide very elaborate care beyond the care that we provide. So, for instance, genetically targeted treatments, PARP inhibitors. Many urologists are not necessarily doing that, or infusional chemotherapy for patients. And from our radiation colleagues, things like targeted PSMA targeted radiotherapies as well. So, you know, we all are growing more and more involved in the care of advanced prostate cancer patients. And I think having a multidisciplinary team, whether it be led by a urologist, a medical oncologist, or another member of the team, is most beneficial for patients.
I think that's a great message. I think maintaining that multidisciplinary collaborative spirit and you know, doing what you can as a urologist, but also knowing when to bring in our colleagues. And so, speaking of which, you commented on kind of precision medicine, personalized care, and so coming back to Dr. Baker here, what are your thoughts on genetic testing for this metastatic prostate cancer population? And what additional benefit or meaningful insights can we get by referring patients for germline testing in this population?
Yeah, well, first of all, I'm not an oncologist. However, it's very beneficial for this patient population with metastatic prostate cancer to be offered genetic counseling and testing. It has not only treatment implications, you know, the example of a BRCA2 germline mutation, making that individual a potential candidate for a PARP inhibitor. And it's not just in prostate cancer, it's for metastatic breast cancer, for ovarian cancer, for pancreatic cancer. So these other individuals with different tumor types also, you know, have a number of targeted therapy options they might be that might be appropriate for them. And it really has caused, I think, a paradigm shift where, you know, when I first started providing cancer genetic counseling services, everybody looked at this as optional. Like, do I want to do genetic counseling or not? Do I want to do testing or not? But now, because the genetic information is impacting their oncologist's ability to decide best treatment options, it's become more relevant and less, even though it's technically still optional, it just becomes more relevant. And of course, the family history, you know, children, I see as a primary motivator for individuals. And I have to remind the patient Yes, but this has benefits for you as well. It's not just your children, it's not just your siblings, your cousins. It's going to benefit you personally to have additional information for your oncologist to help decide the treatment plan. And I'm not sure if we have time, but I did want to touch upon either now or a little bit towards the end, if there is time, about the challenge of how do you even choose a lab for genetic testing, because there's so many of those labs out there. How can you discern which ones are qualified laboratories versus not? And so, just quickly, you need to only utilize the CAP accredited, CLIA certified labs. You need to be aware of what their billing policies are. Do they notify patients in advance if they're going to have a large out-of-pocket expense? How do they handle patients who have Medicare or Medicaid? Do they balance bill those patients, or can they reassure the patient that they will not have an out-of-pocket charge regardless of what the insurance does or does not pay? What are their patient assistance programs? Some of these programs are very generous based on, federal poverty guidelines and number of people in the household. And self-pay prices, which for some people have brought it down in a range where even if they don't meet strictly the criteria that are currently established, we know NCCN guidelines, they're great, but they're just, as I say to my patients, people in white coats drawing a line in a sand. And they're going to miss a number of individuals that have a hereditary predisposition. So we never turn away a patient. If they want genetic testing, we may tell them we can't justify billing it to insurance, but then we'll turn them towards one of the self-pay options that can be as low as $250 out of pocket for 80 or so genes, if that's what they want. We talk about, when we decide between different laboratories, what's the reclassification policy for these variants of uncertain significance? Because we don't always get black or white answers with genetic testing. Some of these genetics labs will proactively reclassify the VUSs by culling the literature on a regular basis, whereas other genetics labs, I've just personally had this experience with a patient I saw back in early 2000, who unfortunately had since passed away from colorectal cancer. She had a concerning VUS at the time, a concerning family history, and the lab never reached out to say that the VUS had been upgraded to a mutation. We just happened to be data mining our database and looked that particular variant up and found that there were other labs that had reclassified the variant some years ago. And so I contacted the original lab, and it turns out that when we didn't have as many choice of labs, they only reactively reclassify variants. So it requires another patient to submit a sample with the same exact variant before they will delve into the literature again. And lastly, some of these laboratories have policies regarding free reflex testing. Let's say the patient only feels comfortable doing a smaller panel, but then once the results become available, while they were waiting for those results, they learned about another relative that had some other type of cancer that wasn't covered with the panel that they pursued. For 90 days, 150 days, depending on the laboratory, you have the option to reflex on that test at no additional charge. And some of the labs even offer free testing for the biological relatives once a mutation is found. So there's a lot that goes into trying to decide what's the best laboratory for the patient in front of you.
Very helpful. Thank you. And, I think that there's a lot of details here that are invaluable. And so then, to close out this evening, I'm going to actually pop it back to Dr. Zhang. And so, I think that, say a patient has gone through all of this with Dr. Baker and comes to you now with this profile, say, let's say we had that question in the beginning, they have a BRCA2 mutation, for example, or any number of other types of mutations. what do you do with this? How do you how do you integrate this into your practice?
Sure. For homologous recombination repair defects, I like to find those out earlier rather than later, so that when those patients are candidates for either single agent PARP inhibitors or for now we have 3 combinations approved for castration resistant prostate cancer, we can actually start talking about those and offer those combinations to our patients. Often those are patients deciding between oral treatments versus chemotherapy in the CRPC space, and they're often choosing the oral combinations. And it's great to have that information in hand. To Dr. Baker's earlier point of VUS as being reclassified as more pathogenic, I do think there's some value for those of us who have access to molecular tumor boards and kind of thinking through molecular alterations within our institutions. It's really helpful to think about that. And then there are some of these BRCA2 reversion mutations that actually restore function for BRCA2 protein. And so it's always a wealth of information when we can sort of share expertise across the institution and think through these mechanisms of these mutations as they come up. And every once in a while, I tell my patients that have these, we find a microsatellite unstable alteration or a tumor mutation high, a tumor mutational burden high tumor. And these patients often will respond to immune checkpoint inhibitors, even though we don't have any currently approved for prostate cancer, but we used the tumor agnostic label for pembrolizumab in those settings. And we've seen some remarkable treatment outcomes with pembrolizumab for those particular alterations. So in general, I'm a big advocate for finding these genetic mutations early and offering treatment options when they come up. There's also a couple of trials that are coming down the pipeline. Amplitude and TALAPRO-3 are both for HRR alterations in the metastatic hormone-sensitive space, and then also a Capitello trial using capivasertib for patients with PTEN loss or PI3 kinase alterations. So those 3 trials will be some that will read out likely in the next few years in the hormone-sensitive prostate cancer setting, and I think we'll have more targeted therapies to offer there.
Very cool. I mean, I think, if you take a step back and really think about what's being done now and what you're talking about, I mean, this is kind of the future. When I was a fellow, I feel like this was what was being discussed as like the future of medicine, like the TCGA project was like a big deal, and sequencing and using, giving people personalized medicine based on their genomic and somatic sequencing and whatnot. And that's the fact that it's actually being done and tested and trialed is really, pretty remarkable. I think we take it for granted sometimes how far we've come.
Yeah, I think, it speaks to the fact that not all prostate cancer is the same, right? There are very aggressive types, and we've all seen them in our clinics. And, if we can drive down to the bucket of why their tumors are more aggressive and try to shut down that pathway. So to your point, we'd love to separate out these disease biology as best we can and target them if we have the ability. I think there's still a lot more buckets, if you will, of prostate cancer that we don't understand how to target, and still much more to learn about them.
Yeah, yeah. I think it's going to creep down. I think even the localized disease, we talk about integrating imaging and genomics and all that, and I think it's going to be, interesting few years ahead of us. I am going to wrap up this evening because I think we're pretty much running up against time. I think we could probably keep going for another hour if we were given the time. But so I will transition to the conclusion phase of this. So this concludes our panel. Thank you so much for joining us. It was a pleasure to have you all. Thank you for your engaging and your comments and your questions, and have a good night.